Ophthalmology, Nuances in Neuro-ophthalmology. So this session aims to cover the basics of neuro-ophthalmology, and these are cases we see all the time. I have with me now Dr. Ankur Sinha, who's coming from Jaipur, and he's going to talk about tips of an effective neuro-ophthalmology exam. Over to you.
Thank you, Digvijay, and thank you, AIOS. So I think we'll have a chit chat amongst us. So I'll be talking about tips of an effective neuro-ophthalmology exam. So for all diseases, we start the examination in terms of clinical evaluation. So it involves the history taking, which would be the ocular examination, visual acuity, fields, pupil, fundus. Then we'll talk about systemic examinations, and then certain investigations, which could be the ocular or the systemic. Now, always elicit the onset of vision loss, because if the vision loss is acute or hyperacute, that is occurring within seconds to minutes, it is either a vascular or a traumatic cause. If it's occurring over a period of hours to days, it could be inflammatory or elevated intraocular pressure. If it is occurring, which the occurrence varies from hours, days, or weeks, it could be a space-occupying lesion or a chronic degenerative changes within the optic nerve or in the retina. So history taking is very important. Look for the onset, whether it is the recent or the long-standing one, the symptoms, whether improving or worsening, associated complaints like headache, vomiting, seizures, systemic history of neurological deficit or comorbid illness, family history of hereditary neuropathies and autoimmune conditions, and treatment history in terms of medications and previous investigations, because some medications can manifest in their side effects as neuro-ophthalmic disorders. Now, it is very important to have the baseline visual acuity, because even if the patient has lost vision, we should know that how the vision was, and it can help us finding out the cause of the disease sometimes. Snellen's acuity is adequate. You don't need a kind of ETDRS always, but check the best corrected visual acuity with the refractive error and the pinhole. Also check the near visual acuity, because it is sometimes lost early in the neuro-ophthalmic disorders. Bedside visual fields does have a role, so you can always get a confrontation visual field, which may help us in terms of pituitary adenoma, ischemic neuropathies, papilledema. And they are also a good guide to make the patient aware that what the patient is missing and what are the potential risks of the particular neuro-ophthalmic disease which we're talking about. So the patient looks, the right eye looks into the left eye of the examiner, and we ask the patient to count the fingers or see the fingers or the hand movements in various quadrants so that we can know. And here we are looking in terms of vertical as well as horizontal midlines, if you're thinking in terms of space-occupying lesion versus an ischemic optic neuropathy. Never miss pupils. Never dilate the person, person in the OPD by a blanket kind of an order to the staff that all the patients should be dilated, because you assess the pupil size, the reactions, the near response, and the pupillary dilatation reaction, and also test the RAPD if possible. We don't need, various kinds of pupil gauges or handheld pupillary cameras. We just need a scale or a pupil marker, usually behind our occluder, to assess the size of the pupil, which can be easily done in the OPD. So assess the pupil size, check for the diameter in the darkness, light and near. A difference between the two eyes of more than 0.4 millimeters can be termed as an isochoria. Check the reaction of light. For that, dim the surroundings. Ask the patient to look for distance. Do not ask the patient to attempt for near vision. And check the pupillary escape, which is dilatation followed by constriction followed by dilatation, which is seen in optic nerve and retinal disorders. Check the latency and speed of constriction. Also check the consensual light reflex. So also check the near response in terms of near triad. Again, a dim light and accommodative target should be used in these patients. Check for the reflex dilatation, which could be a dilatation to a painful stimulus or a sudden noise. Dilatation lag may point, and within an isochoria may point towards Horner syndrome, and sometimes it can be normal. In the light near dissociation, the reaction to light is always impaired, and the near the constriction is always there. Check for the RAPD, which can be tested with the help of Marcus gun phenomenon, where we cover the light and see the response of the abnormal eye. Or it can be done with the swinging flashlight test, which I think we all know how to do it. You can always do an edge light pupil cycle time with a slit lamp, which is very handy. It is useful in when the diseases are symmetric, having involvement of both the pupils. So what we do is we place a small, So we put a small light beam, so it causes constriction of the pupil, and it cuts off the light, so the pupil dilates again. So calculate the number of cycles in 1 minute and check for each cycle time. So if it is longer than 954 milliseconds, it is definitely abnormal. To do a pharmacological testing to check for the supersensitivity with the diluted pilocarpine, a pilocarpine to look for pharmacological blockade, cocaine or apaclonidine for sympathetic effects, phenylephrine or hydroxyamphetamine for postganglionic sympathetic effects. So they are always handy and available to us. Now this is a case of 12-year-old boy with a drooping of lids and right eye mild ptosis. So we can see that the right eye pupil is smaller as compared to the left eye. And the patient was diagnosed as Horner syndrome, and this is the MRI thorax. So here we can see a large paraspinal mass, which turns out to be schwannoma. The patient undergoes surgery for the same. So this is another case where we can see that the left eye pupil is dilated and it is abnormal. So it's a 48-year-old male who comes with anisocoria where the left eye pupil is larger as compared to the right eye. And we see the direct reaction to the light. So when we shine the light here, it constricts absolutely fine. But when we shine the light to the left eye, it doesn't constrict so well. So probably we are dealing with a left eye abnormality of the pupil. We check the consensual light reflex. I had put a small light on this side because so that we can see the reactions when we are trying to record. So when we shine the light in the left eye, the right eye does constrict. So and when we shine the light in the right eye, the left eye doesn't constrict. So there is a problem probably with the efferent pathway of the left eye. So, and on the slit lamp, when you measure, when you record the movements, so this is more like vermiform movements of the left eye as compared to the concentric movements of the right eye. So you can see there's a little bit of time which is required to constrict the left eye pupil. And this is the presentation when the pupil is dilated, and this is after reading. So the near reflex is working, but the right light reflex is not working in this patient. So he's diagnosed as Aries pupil and was given asymmetric near ad because this was his complaint. He did not have significant photophobia, but still a photochromatic glasses was offered if in case he has significant light intolerance in the day-to-day activities. So fundus examination is important. It should be done after noting the pupillary reflexes. Do a direct ophthalmoscopy, slit lamp examination. Always perform in direct ophthalmoscopy so as to know the whole picture of the retina, because sometimes you can have disc edema because of peripheral retinal diseases, which has to be ruled out. Systemic examination is a must because at times you have a very high blood pressure and the patient is presenting because of grade 4 hypertensive retinopathy with disc edemas. So check the pulse, BP, check for the CVS, respiratory dysfunctions, abdominal, and above all neurological dysfunctions. If possible, do a full neurological examination in terms of gait, orientation, attitude, cranial nerves, motor system, and the sensory system. Cerebral system should not be missed out, and if you're not confident, you can always take the help of a neurologist. Check for the ophthalmic investigations like the color vision, contrast, visual fields, and the visual evoked responses or other tests which can be done for these patients in terms of optic nerve function. Check for the color vision because it may be impaired in the optic nerve disorders, especially the red-green one. The macular disorders will have blue-yellow dysfunction. Optic neuritis can be have a red desaturation. So formal testing should be done with the help of Ischiaras or any other forms of color vision. Contrast sensitivity is a very sensitive tool. It may sometimes be affected before the visual acuity, especially in the optic neuritis, and it should be done in these patients. So a formal contrast sensitivity measurement is usually available in most of the electronic visual acuity testing meters, so we can always do on them. There's a role for systemic investigations, and there is a whole plethora of tests. So based upon the signs, symptoms, and what you expect, order specific investigations rather than asking for a blanket investigation of each and everything. Montougs can be important because the TB can manifest like any neurological disorder or neuro-ophthalmic disorder. Radiological investigations may include chest X-ray, CT scan, MRI of brain and spine. So in the end, I would just like to say a methodical exam and a good workup is a must to arrive at a good diagnosis, which can sometimes be life-saving for the patient. Thank you.
Thank you, Dr. Ankur, for covering that and kick-starting the session. I'll now invite Dr. Dipankar Das, who's here from Guwahati, Shri Shankar Dev Netralay, to present. He also has his own IC going on in parallel, so it's great for you to have come here. And so the talk of Dr. Dipankar Das on OCT in neuro-ophthalmology.
Good morning. I'd like to thank Dr. Digvijay for inviting me for this and including me for this IC on the topic of use of OCTs in neuro-ophthalmology practice. I do not have any financial disclosure in this presentation. This is purely an academic one. Now, in this room, we all are familiar what is optical coherence tomography. It's an evolving technology, non-invasive, non-contact imaging of anterior segment and posterior segment, and it's just an optical biopsy of the tissue in question or tissue in scan. Now, this uses a low coherence interferometric methodology to scan those anterior segment and posterior segment pathologies. This was discovered or innovated in MIT, Harvard in 1990, and after that it was lot of innovation from time domain OCT, spectral domain, SWAP-SOT, CIRRUS, and now we know that OCT has come. But for a this short present is very difficult to explain all the neuro-ophthalmological thing, because we have to know the machine parameter of the OCT and the OCTA or different instrumentation of OCT. For example, time domain OCT, which was innovated in 2002, uses a wavelength of 810 nanometer. You see there was a 400 A scan can be done in per second, and the diode laser is used. And now once the spectral domain OCT is used, much more higher scan can be done in less seconds, and you can appreciate choroid and retinal pigment epithelium. Now for the protocol, the 3D OCTs, RNFL protocol, which gives also a GCL and IPL thickness measurement. SWAP-SOT OCT again 1050 nanometer the wavelength is, and it can scan 4 lakh A scan per second and 5 micron resolution. CIRRUS OCT, where you also have a GCL, there is a macular GCL and IPL parameter. OCTA again has a some usefulness in the neuro-ophthalmology scanning. Now what we'll see here is some of the peripapillary nerve fiber layer thickness measurement, retinal thickness, particularly the macular GCL and IPL, and the optic nerve head morphology. Now, what are the prerequisites? You have to have a trained personnel who scan the OCTs, and for the patient point of view, you need to have a good focus, well-centered eye, and eye without a movement. Now, normal RNFL you have to see, or the post-scan mapping, the deviation mapping, particularly with the normative data, the RNFL calculation circle, and one extracted horizontal tomogram, extracted vertical tomogram, neuroretinal limb thickness, RNFL thickness, and RNFL clock hours, which is seen in these different zones of involvement. Now, optic neuritis and anomospectral disease is very important for the neuro-ophthalmologist. The RNFL OCT can detect subclinical optic atrophy and the thinning. RNFL thinning is evident after optic neuritis, and maximum loss can occur by 3 to 6 months. In multiple sclerosis, thinning is also occurring in unaffected fellow, that's very, very important, and temporal quadrant involvement in papillomacular bundle. You see, this is the optic nerve, typically the temporal aspect, which is the thinning in scenes. Even if you see a papillitis, this is the temporal aspect where you see the edema. Now we see the anomospectral disease. The vertical, that is a superior at the inferior quadrant, is involved, and this is the one of the characteristic when you scan your RNFL OCT scans, you can immediately come to the diagnosis. Now, GCL and IPL in optic neuropathy, this is the 3 scans in same patient, with top showed acute phase followed by progressive thinning in 6 to 12 months. For optic neuritis, even the what you call toxic optic neuritis, GCL and IPL scanning is very, very important. Now, this is very, very important when you see the microcystic macular change in retinal OCT. Basically, it has been seen that these changes which reveal a microcystic macular change in the inner layer of the neuroretinal layer, in this, which is shown by the arrow red. Important thing is that it has been reported to occur 20% of anomospectral disease and 5% of the case of MS, which is suggestive of greater disease activity. That's very, very important. Now, we know that in the Western population, also in our country, Alzheimer's disease or Parkinson's disease is very, very important, where you get a peripapillary retinal nerve fiber layer reduced. In Alzheimer's disease, OCT shows a decrease in RNFL reflection in each examined quadrant, which is particularly important at temporal zones or temporal ones. Thinning of the inner retina at the fovea and flattening of the foveal pit is seen in Parkinson's disease. Now, OCT in pituitary tumor, this is very, very important because as it's seen in the tip of the what you call anterior visual pathway, PRNFL does not have too much information, but macular GCL have importance. Hemianopia in perimetry can present with hemiatrophy in macular GCL and IPL. Macular GCL and IPL change occur before the peripapillary retinal nerve fiber layer change. And most important is patient with objective PRNFL loss and macular GCL and IPL thinning at the time of surgery, for example, pituitary tumor surgery, were less likely to have post-surgery recovery of visual acuity and visual field defect. Now, NAIN, as we know, if you see the disc, this is a small cup. This is an example of a 80-year-old female male with a diagnosis of NAIN in the right eye. You can see the quadrant involved in the left eye is the upper quadrant. Usually, the inferior quadrant is involved. So, the visual field showed the changes in the upper quadrant. Despite of edema on RNFL analysis, there is a thinning inferiorly in the right eye of the ganglion cell layer. 2 months later in the patient, RNFL measurement normalized in the right eye and GCL showed thinning inferior greater than the superior. And now you see the optic nerve, the raster scan that is being done in the optic nerve head drusen. You can see this drusen has a hyperreflective changes and they are above the lamina cribrosa. There may be a hyporeflective changes. And what is important in the pseudo papilledema, there is something called peripapillary hyperreflective ovoid mass, which is nothing but the ischemic changes in the nerve endings. I take just 1 minute. Papilledema and pseudopapilledema, one important thing is that just see the in the raster scan, just see the RP Brooks membrane. If it is pointing to the inner side of the retina, then it is because of the edema, and you need to see the hyporeflective triangular zone between the photoreceptor and the RP, and also you see the temporal side of the retinal layer where you see corrugation, which can be evident. And pseudopapilledema, we don't see that hyporeflective triangular zone, and you see the RP Brooks membrane is deflected downward. Negative deflection is seen, which is consistent with pseudopapilledema. Now, just a few lines for OCTA, peripapillary radial capillary network visible in OCTA, unlike FFA. The reduced peripapillary radial capillary and network perfusion is seen in optic neuritis, ischemic optic neuritis, Leber's hereditary optic neuritis, and autosomal dominant optic neuritis. And absent localized perfusion can be seen in arthritic anterior ischemic optic neuropathy. So in conclusion, OCT is an important in vivo imaging tool in neuro-ophthalmology diseases. It provides a various sensitive objective measurement. And thank you for patient hearing.
Thank you, Dr. Dipankar, for your talk. Is there any questions for Dr. Dipankar? All right, then we'll move on. Thank you for coming in. We'll move on now to Professor Rohit Saxena, who's going to talk to us about approach to a pale or swollen disc. So I think we get to see these both in our practices fairly frequently. So sir is from RP Center. He's a professor there and heading the neuro-ophthalmology services at the RP Center.
Thank you, Digvijay, for the opportunity, and AIOS for accepting this course. first, whenever you want to see the disc, it's most important, and we were taught in residency, see a few thousand fundi, and then you'll actually start understanding how to differentiate anatomy from physiology, normal anatomy from pathology. So these are the key things that you need to look for whenever you're looking at the disc: the color, the size, shape, the margins, the cup, the rim, particularly the color of the rim, the shape of the rim, the vessels as they emerge, how they are appearing as they go onto the surface, or they come out of the disc and onto the retina and the peripapillary area. So some are definitions that we'll start off with when we're defining disc edema. So optic disc edema is true disc swelling due to any cause. So there is no etiology associated with this. There is just disc edema. Papilledema is essentially conventionally termed as true disc edema caused secondary to raised intracranial pressure. So there is so we are suggesting in our diagnosis that this disc edema is due to raised intracranial pressure, and pseudopapilledema would be that there appears a disc swelling, but there is no actual fluid edema or anything there. On the other hand, the atrophy. So essentially, the response of the optic nerve, is like a dog. You trouble the dog, little, it barks. A lot, it just lies down and dies. So that's what is happening to the optic nerve. There's edema, initial insult, injury, edema, swelling. It is very rarely that you'll be able to, just on the basis of the edema, get a lot of diagnosis, but it sometimes is suggestive. And over time, there's just going to be atrophy and pallor of the optic nerve. Atrophy would be a pale disc with defective visual function in one form or the other. Again, important thing to remember is that it's just a response and it's not a graded response. So amount of disc pallor or edema may not necessarily correlate with the visual functions. So you have disc edema. The first thing, as we started with, is looking at whether what's happening to the other eye. So whether the disc edema is bilateral or it is unilateral. So if you have a bilateral disc edema, you are more interested to find out a systemic cause. So possibly a systemic or neurological cause may be there. So papilledema, pseudopapilledema, hypertensive retinopathy, occasionally bilateral papillitis, and of course other compressive neuropathies or systemic disorders that could cause a disc edema occurring in both the eyes. When you have a unilateral disc edema, you may tend to get an early suggestion of a hyperemic or pale edema that may be there. Not often very easy to differentiate, but a hyperemic disc edema may be seen in any papillitis, ischemic neuropathies also in the initial phase, pseudopapilledema, CRVO related, or even in asymmetric papilledema where the disc edema starts in one eye and maybe over time will go on to the left eye, to the other eye. And of course, it may be the other eye has an optic atrophy, essentially meaning that this is a sequential involvement of the optic nerves, one eye followed by the other. It's more importantly to differentiate papilledema from pseudopapilledema, so you can see the three things put together, one above the other. So the top one is pseudopapilledema, where you can see the vessels are there. It looks like swollen, but it's a small disc. There is no cup. The margins are not sharp, but the vessels overlying this are absolutely clear. Contrast that with the second slide, where it's absolutely engorged disc. The vessels are not visible. There is an absence of the cup, but you can see the exudates and edema and hemorrhage all over the disc. And again, on the bottom one, you can see that while there is a little bit of blurred margins on one side or the other, but the hemorrhages, the exudates are very far removed from the disc also. So if you have normal retina intervening in clear signs of hemorrhages or exudates, you know that the disc is not primarily involved in that. So this is again another just contrasting between a true disc edema and a pseudo disc edema. Essentially, just a quick overview. Papilledema, a raised intracranial pressure, could be multiple reasons, causes. You'll just look for an enlargement of the blind spot and peripheral constriction as the early signs, and over time it could go on to involve the rest of the entire visual field. The causes could be anything: solid tumors, so you could have raised ICT because of a large intracranial tumor. It could be fluid related, so you could have hemorrhages, bleed anywhere, post-trauma, or again infection that can prevent outflow obstruction. So you could have a hydrocephalus, you could have an aqueductal stenosis causing back pressure, so anything. And of course IIH, which is the most common thing that we see. The most important thing that we're going to look for is an MRI, to rule out an ICSOL, and of course look for any other cause. That becomes the most important thing. Followed that up, if the fundus appears to be normal, or there are signs of meningitis, or you suspect, you do a lumbar puncture, and of course work with the neurologist for all this. So neuroimage bilateral disc edemas, rule out ICSOLs, may require a CSF pressure and imaging, and then you manage papilledema accordingly. Weight loss, very, very important. Acetazolamide and increasing doses, the most common ones, and of course surgical options including optic nerve sheath fenestration remains. Just a quick again overview of unilateral. We talked about hyperemic and pale. Sometimes pale disc edema, anterior ischemic optic neuropathy may have pallor associated or setting in very early, giving us a suggestion. But hyperemic disc edema would be papillitis, asymmetric papilledema, compressive neuropathies. Papillitis, most commonly optic neuritis, but of course unilateral disc edema could be due to anything, any inflammatory autoimmune cause affecting the disc could present with a disc edema or a papillitis kind of picture. Classical features of optic neuritis we have discussed earlier in this conference, and I won't go in details because of the lack of time, but essentially earlier we used to think that no treatment is an option for optic neuritis. Now IV methylprednisolone has become the standard of therapy, and irrespective of the cause, including NMO, MOG, or multiple sclerosis related, our first treatment does become IV methylprednisolone, followed by whatever the rest of the intervention depending upon the diagnosis. A pale disc edema, you're looking at an arthritic or a non-arthritic ischemic optic neuropathy. Non-arthritic forms the sheet anchor of them. It's very, very rare to see an arthritic, but it is important to differentiate it because arthritic AION is an emergency. The NAION would present with a little middle-aged or older patient with vision or field loss related things, particularly in altitudinal field loss, a sectoral disc edema, or going on to a sectoral atrophy, and the other eye being a small disc. Whenever you have an NAION, the most important thing is to identify risk factors and manage them, because recurrence in that or the other eye are very frequent unless the cause or the etiology behind the ischemia is managed. Again, essential control of risk factors is the management, and any other treatment has not found to be very effective. Arthritic is just important to differentiate. If you suspect an ESR C-reactive protein which is severely elevated, would give us a suggestion, but any patient, elderly patient with headaches, jaw claudication, sudden loss of, severe loss of vision, scalp tenderness, fever, loss of appetite, all these are, suggestions of, so as I mentioned, advanced stage, all these symptoms, initially transient visual obscurations, bilateral sequential involvement, all these are signs, and of course the most important thing is to manage it with high dose steroids urgently, immediately. So that's why arthritic becomes important. Just to show you another ischemic optic neuropathy, you can see a very small Sutton involvement. You can see that the disc is just sectorally involved, and the other eye is a small disc with the absent cup. So these are conditions, again, another appearance of a disc edema, but when you see, we talked about brucins in the previous OCT picture, but that's what you need to look out for. True versus pseudo disc edema. And optic atrophy, you can differentiate primary versus secondary, giving us a little etiology based idea. So primary would be because of trauma or issues related to the anterior part. So anything that is causing absence of edema and causing damage to the optic nerve would present as a primary. Clear disc which does not have blurred margins, it's a chalky white disc. Whereas secondary is usually secondary to any cause of inflammation or edema into the optic nerve, presenting with a blurred margin or a dirty looking disc with sheathing of the vessel. So these are possible ways in which we can identify. And another thing that we need to always remember, that there is something that excavated discs need not necessarily be just glaucoma. Even in alcohol toxicities and space occupying lesions, they may present with something like an excavated disc. And it's always important whenever a patient presents to search for the cause of disc edema. So thank you very much for the opportunity and for patient listening.
Thank you, sir, for covering that very well. Any questions so far before we move on to the next topic, which is now when the disc appears normal and there's a vision loss, then what? So that's the next topic. That's okay. That's okay. So So let's move on from a swollen or a pale disc to a situation where the fundus appears absolutely normal. So these are diagnostic dilemmas, because and these are you do get to see these cases fairly frequently in our practice. So it's not something that is unusual. There is a financial burden, there is a social burden. The patient goes to different places. Everybody says everything looks okay. You're saying you've got a vision loss, and so that becomes kind of like an issue for that patient. And there are sometimes medical legal implications as well. Of course, there is a cause somewhere, and the causes could be involving any of the visual pathway, right from the macula up to the brain, the cortex, and there are some situations where we get patients who are also malingerers or having some functional vision loss as well. Occult macular dystrophies are there, situations which could be involving either the rod system or the cone system, and these are you will not find any change when you look at the fundus initially, but if you do a careful examination, you do sometimes find some changes. You can get help from tests like the multifocal ERG, though the normal pattern ERG would be normal. You could use the OCT, the ganglion cell complex scans particularly are able to pick these up. But we'll focus more on the neuro-ophthalmic conditions in this particular presentation, and we'll shift to retrobulbar neuritis, just like Professor Rohit showed a case of papillitis. So this is a situation of optic neuritis where the discs appear absolutely normal to look at. There is an RAPD in the eye that is affected. Color vision would be affected out of proportion to the vision loss that's there. There could be pain, it could be painless, and there could be associated other neurological abnormalities as well. So you need to be able to recognize RBN as a diagnosis, particularly when you're having a subacute vision loss, in the typical age group. And of course, the treatment for the you need to investigate these cases. Let's look at one case which is of RBN, which is a young female, about 32-year-old female who's presented with vision loss in the left eye, as you can see here. There is an RAPD, and that's why the pupil, you should not dilate blanketly all your cases, as Dr. Ankur in the morning pointed out. And when you look at the fundus, it appears absolutely normal. So there is no change whatsoever. Things appear absolutely normal in fundus. But when you look at the MRI, you can see that there is an involvement of the optic nerve on the left side along that tract. And so this is a case of retrobulbar neuritis and would require treatment with IVMP. Another form of optic neuropathy where the fundus may appear absolutely normal is a nutritional deficient optic neuropathy. These usually have some risk factors involved, whether it's malabsorption or alcoholism or something else that is going on. In the initial period, the discs would appear absolutely normal, though over time a disc pallor would set in. These are associated with central centrocecal scotomas, and again need to be recognized in line with the risk factors. Something which is presenting similar is the toxic optic neuropathy, and I think we have been seeing a lot of these cases in India, particularly with ethambutol being used now for the longer period, and there are implications. The methanol is implicated usually in the more in the acute phase. You would have some symptoms or signs that you can see. In the chronic phase, it would end up with a disc pallor, but more important for us is the ethambutol, amiodarone, chloramphenicol, or some of these other linozolid related optic neuropathies. Let's come to a case here. This is a young male boy who was presenting thin build, was having vision loss over time. Vision had come down to 6/12 in both the eyes, and remember, these are somewhat symmetrical vision losses that you'll get in these cases. You looked at the color vision was within normal limits initially. Contrast slightly decreased. The fundus appeared absolutely normal. There was no family history of any disease. But when you look at the visual fields, you can see that there was a field defect in both the eyes, a generalized depression with a slight peripheral constriction and a central field defect. So this was a patient. When you further took history, there was no ETT usage at all, but it turned out that he was somebody who was doing an inhalation abuse, and this was an inhalant abuse associated toxic optic neuropathy. So you could have these rarer situations also that you come across. But of course, this is also the age where you want to look at Leber's hereditary optic neuropathy, and I'll come to that next, what that means, because LHON also can present in the same age group. Over time, the patient had a disc pallor that developed in, but once after he had his de-addictions center, and he was basically given some treatment by multivitamins and better nutrition, he did improve. So this is kind of one of those situations where you have to be alert to be able to catch these, because initially everything appears quite normal. Leber's hereditary optic neuropathy is something we are seeing in the adolescents age group. You could have some changes on the disc initially, like some telangiectasias, hyperemias, but these are essentially a mitochondrially inherited disease, and over time would lead to primary optic atrophies in both the eyes, which is gradually progressive. Again, needs to be recognized, and a genetic testing can pick up the mutations for you. Rarer optic neuropathies, and I see these sometimes as in the multi-speciality hospital, could be cancer-associated neuropathies. These are paraneoplastic syndromes that are happening. Also, there could be associated maculopathies, and these again need to be recognized in the line of the background of the disease that they're actually in. Posterior ischemic optic neuropathy is an ischemic optic neuropathy seen similar to the anterior ischemic optic neuropathy in terms of signs and symptoms, except that the fundus initially would appear absolutely normal, usually associated with shock or some kind of a fluid loss or a hypotension that is happening, and often would be seen after major general anesthesia surgeries that are done, particularly where there has been some sort of blood loss as well. So again, these are some things you have to be able to recognize and manage and treat early. Traumatic optic neuropathies, again, at the onset would have no change on the fundus whatsoever. If there has been a direct or an indirect trauma, there would be no change at all on the fundus, and over time, of course, a pallor may set in, but the pupils are going to give you the answer. So again, pupillary examination is very important, and this is something you can do even in a patient who's bedridden, who's in the ICU. Here we are showing a young patient who had an injury. Initially the fundus appeared normal, of course slightly pale here because this picture was taken a bit later down the line, but you could see that there was a fracture inside on the orbit, and this was a case of traumatic optic neuropathy. Needs to be treated early for the best outcome. That's there. Cortical visual impairment is something that we see in cases where, in cases like HIE or ADAMS, where there has been an involvement of the cortex, of the occipital cortex, leading to vision loss. Again, the fundus would appear absolutely normal. Microtropias are small angle squints with amblyopia. Small central scotomas are there. Again, nothing would be visible. You need to also recognize malingering. So this is sometimes done with a positive, with some kind of a gain that the patient is looking for. It could be positive or negative. You have to be smarter than the patient to catch it up. There are plenty of tests that are described, and you need to be able to know some of these and use them and be able to catch out the patient. But differentiate this from hysterical or other forms of conversion disorders, which are actually psychiatric situations which require your support from your colleagues. Lots of neurological disorders like amaurosis, Fougax, or other cerebral causes can also cause vision loss with a very normal appearing fundus, and something that we need to be able to recognize. So remember, this is a situation where you have to have a high attention in terms of the history, in terms of the details, and in terms of examination beyond the fundus to be able to catch these situations and diagnose them. So thank you for that. I now invite Dr. Ashwin Gandhi to speak to us on visual fields and localizing the lesion. Again, something as neuro-ophthalmologists where we have to, work as detectives to be able to locate that.
Thank you. Thank you so much. Thank you, Digvijay, for inviting me for this session. So there are a few disclaimers. One, neurological visual fields ideally should be tested on a kinetic perimetry, but they are not very popular, not readily available. Confrontation test is something which we should all know and deploy even in our general ophthalmology practice, because it can really screen out the serious problems, and that's something which Ankur already spoke about. So I'll restrict my talk to the automated static perimetry. So if you encounter a visual field like this, it's actually not very difficult. The first thing you look for is, are you able to see blind spot? Because that will give you a clue, if you're not really very familiar, to say whether this is a temporal defect or a nasal defect. And you see very clearly that there is no blind spot on either side. So telling you that this is bitemporal hemianopia, a very clear-cut case of a bitemporal hemianopia. You know that this is a neurological visual field defect, and you localize the lesion to optic chiasm. But it's not always, and this patient actually had this pituitary lesion, but it's not always that we encounter such clear-cut cases. This is what we will see in our day-to-day OPD. So now here we have a patient who has this kind of visual field defect. Now let's look at the left eye. You see the left eye is a complete generalized reduction of sensitivity of the left eye. So this is something which will happen in an optic nerve lesion. So if you find a unilateral region where you have this kind of problem, you know that that optic nerve has a very severe or profound visual impairment. Now couple it with, so this is a blind spot here. So couple it with a supratemporal defect in the other eye. This again is a sign of a chiasmal lesion. This is called junctional scotoma, an optic nerve lesion in one side and a supratemporal lesion in the other side. So this is again a feature of optic chiasmal lesion. We go a little further and say that can you localize it even more, and what we are dealing with here. Again, you look at the left eye has been very helpful by becoming completely hemianopic. So there is a complete hemianopia of the left side. You know that. So you know that you probably are dealing with a chiasmal problem. But how does the right eye give you a clue? So here you have a lesion here which is on the nasal side and a temporal side in the inferior part. So what now you know is that there is a complete temporal defect in the left side, inferior temporal defect of the right side. So you know that you have a chiasmal problem which is coming from above, because when you have a predominant inferior defect of one side, you know that the chiasm is being compressed from above. So that's one first information that we got: chiasmal lesion which is above. How do we fit in this? So this is like an arcuate defect. So arcuate defect also is a sign of an optic nerve lesion. So now you know that there is a bitemporal defect, chiasm being compressed from above, and because the right side optic nerve also is showing extra defect, you know that that particular lesion is also veering towards the right optic nerve. So the bitemporal chiasmal problem with a lesion going towards the optic nerve is how you will localize lesion just by looking at the fields. However, one has to remember that bitemporal hemianopia is not always neurological. There are, or it's not always compressive. There are lesions like this which can give you a visual field defect which may appear predominantly bitemporal, like tilted optic disc, nutritional optic neuropathy, especially ethambutol related toxic optic neuropathy, can present with bitemporal defect. Enlarged blind spot sometimes can be confused with bitemporal defect, or RP initially can have a predominant temporal defect. Contrast it with this. Here you are able to see the blind spot. So though this field appears like a complete hemianopic defect, but this is a binasal hemianopia. And when you have a patient with binasal hemianopia, what you are looking at predominantly is an ocular cause or a problem within the eyeball. It's very rare for an intracranial cause to cause a clear-cut binasal hemianopia. So that's about the chiasmal lesion, because that's something which is often missed or misdiagnosed with NTG, optic neuritis and whatnot. And a problem can be treated if there is a chiasmal problem, and you can effectively save the patient's vision. Now we move on to the second scenario. You see here a patient who has a predominant inferior defect. So this is inferior altitudinal defect, and your diagnosis would be AION. AION generally causes because it's a vascular event and it follows the vascular pattern of the optic nerve, blood supply to the optic nerve. So it causes an altitudinal defect. Inferior altitudinal defect is much more common than the superior altitudinal defect. What about here? You see, so first of all, if you have a visual field isolated, you know that this is a supronasal defect, like an arcuate field defect. But always remember that the visual field can also mimic anything which is happening in the eye. This patient actually had a branch retinal artery occlusion. We move on and say, okay, this is another example of a visual field defect where there is a visual field problem in both the eyes, which is respecting, by and large, respecting vertical midline. Please remember, in glaucoma, we look at very specific changes and then look at mean deviation and pattern standard deviation, because that's what will guide us for the treatment. While in neurology, we are only looking at the patterns, because that's what will localize the lesion. So here what you're seeing is that there is a left-sided defect which is predominant inferior. So this is left homonymous inferior quadrantenopia. You're looking at mainly, so this is what is also described as pie in the floor. So generally the lesion would be in the parietal lesion, a parietal area, versus here what is described as pie in the sky. So you see this is a predominant left-sided lesion, superior quadrantenopia. Here you're looking at temporal lobe. So if you have a homonymous defect, that is one side of the field is affected in both the eyes, and if it's inferior, you're looking at parietal lobe. If it's superior, you're looking at temporal lobe. Any idea what we are dealing with here? Looks overall okay, but what do you think? So you see here, these are blind spots which are slightly enlarged. So this is a sign of an acute papilloedema. Generally, enlarged blind spot occurs in an acute papilloedema. So you have a optic disc which is questionable or which is swollen, and if you see this kind of picture, you know that maybe you are dealing with papilloedema, as what Rohit discussed. What about here? This is a very specific pattern. These are more important. I mean, they are rare, but they are more important, especially for residents or fellows who are going to write the exam. So these are the kind of defects. This is called sectoranopia, and this is generally a sign of a problem in lateral geniculate body. You can either have a defect like this, or only these two triangles can be affected. Again, because of the blood supply, the way LGB is supplied. What about here? So you have, if you just look at this, you know that there is a right superior quadrantenopia. And then if you only look at this, you know that there is a left inferior quadrantenopia. So basically, patient had a stroke on both the sides. So where the superior one, so right superior, so patient had a left temporal problem, and the left inferior patient had a right parietal problem. So to conclude, whenever you're looking at the visual fields, the first thing to do is to have both visual fields together. Placement of the visual chart is very important. The right visual field should be on your right side and left visual field should be on your left side. Look at the gray scale first, because that pattern will tell you whether is there any particular pattern that you are able to see, which immediately gives you a diagnosis. A mean deviation sometimes can be important, especially when you are following up a patient, when you have done a serial visual fields, and if you see a clear change in mean deviation, whether it's improving or deteriorating, mean deviation can give you a clue. Once you have placed the visual fields, first question you ask yourself is visual field defect monocular or binocular? Monocular is much more likely to be retina, optic nerve, or very rarely cortex. Binocular, you're looking at chiasm, where temporal visual fields will gone, and post-chiasmal, where a homonymous hemianopia, that means a visual field temporal side of one side and nasal of the other side, is generally involved. Thank you.
Thank you, Dr. Ashwin. Your presentations are always pretty thought-provoking. I enjoyed one of those that you had at that PG program that we were doing. I now invite Dr. Mahesh, who's going to talk to us about how. Yes, you have a question there. Dr. Mahesh, you can come here in the middle.
So, great question. There are three visual fields which we generally deploy, which is 30-2, 24-2, and a screening which can be 60 or 120. Now, the general dictum is that if you know that there is a clear-cut optic disc edema or there is a pale disc, so there is an optic nerve problem, in all probability you will pick up the visual field even on 24-2. Now, you don't have an optic nerve, a very clear optic nerve problem, so you're looking at the pattern. Most of those defects again will be picked up by 30-2. It's very rare that everything else is abnormal, everything else is normal, but patient is insisting that he is not able to see in the periphery, is where you go to a screener.
So I now invite Dr. Mahesh, who's heading Neuro-ophthalmology at Aravind, to speak to us as how electrophysiology is our friend. And in fact, in a lot of these situations, particularly where we tend to get a normal-looking fundus, I didn't purposefully cover it there in those cases. Electrophysiology really helps us, pick up the lesions. So over to you, Dr. Mahesh.
At the outset, good morning. At the outset, I would like to thank Dr.Digvijay Singh for having included me in this instruction course. So the topic is electrophysiology, and what is electrophysiology is a non-invasive test, a functional indication related to the different locations and cell types within the visual system. So these are all the various electrophysiological tests which which is self-explanatory. You can see this EOG, full field ERG at these levels. And what will be interesting as a neuro-ophthalmological course is we'll be interested mainly in the visual evoked potential as well as the pattern ERG, and these two are more relevant in the neuro-ophthalmological perspective. So I'll be speaking only on these two things. Of course, the multifocal ERG is focused on all these points. So a VEP is defined as a function of the entire visual pathway from the retina to the area of the visual cortex, and primarily reflects the central retinal projection to the occipital lobes. In a nutshell, we can say that VEP is a localized form of an electroencephalogram of the occipital lobe. So that is what a VEP is. These are all the various electrodes which are placed. And differentiating VEP from a MRI is, VEP is more of a functional assessment, whereas MRI is more of an anatomical assessment. VEP gives a physiology of the anatomical pathway, and whereas MRI gives an accurate information of the structural defect. VEP lateralizes the lesion but doesn't localize it into a particular point, whereas a neuroimaging localizes it to a particular point. However, the VEP is useful grossly in assessing the optic nerve function to be affected in the prechiasmatic or in the anterior portion of the optic nerve. Indications for a visual evoked potential. It is indicated for functional defects in the upfront visual pathway. In infants or non-verbal infants, patients with intellectual disability and aphasic patients, malingering patients, when the symptoms do not correlate with the signs, we can employ the VEP. Opaque media, unexplained vision loss, where we don't know whether it is an optic nerve or a macular problem, we can employ the VEP. Not only that, we can also do it for prognostication purposes, as we will be seeing in subsequently in cases of optic neuritis and multiple sclerosis in the opposite eye. So all these VEP standards are created by the International Society of Clinical Electrophysiology of Vision Guidelines, ISEF, which is as it is called as, and these are all the gross parameters which are assessed. Ideally, we look at the latency and the amplitudes of the P100 wave. So latency is the implicit time which where there is a peak of the P100 wave, and the amplitude is the distance between the peak and the trough of the P100 wave. There are three different modalities of testing this. A gross flash VEP, where there is just an on and off pattern such as this one. So this is done when the visual acuity is extremely low and we just need to know the integrity of the visual pathway. So there is the other pattern, on and off pattern, where there is a we just switch on the pattern and switch it off. This is used occasionally in cases where the media is hazy, but the most common pattern which is used, the pattern reversal, which alternates between this checkerboard and the other checkerboard between black and white, and this is most commonly used. So how do we interpret the pattern VEP which is commonly used? We look at the amplitude loss. If the amplitude is lost, it indicates an axonal loss, which means the nerve has been destroyed. So this ideally occurs in a ischemic optic neuropathy or toxic optic neuropathy sometimes, where there is a destruction of the axons. Other thing we look for is a peak delay, as we saw the implicit time. Peak delay means usually it indicates a demyelination because there is a conduction delay. We all know that conduction is done by the myelin sheaths, and whenever there is a demyelination, there is a conduction delay, and it classically occurs in demyelinating optic neuritis and sometimes in aging conditions. Sometimes both the amplitude and the implicit time is affected, and these can occur in nerve compression such as compressive optic neuropathy, like tumors. What tumors does is actually destroys the nerves as well as delays the conduction also. So in the initial phases of the tumor, there is just a latency delay, and if we can catch that and we can operate the tumor, for example a pituitary tumor, we have seen cases where it can recover completely to 6/6 without any residual visual field loss. But however, if the tumor is prolonged, it can lead to axonal loss and amplitude problem also. So now what is this pattern ERG? Pattern ERG is derived from the macular retinal ganglion cells as well as the rest of the retinal ganglion cells. So why VEP alone is not enough to detect a neurological dysfunction? Because VEP is predominantly from the occipital lobe, and majority of the occipital lobe is from the macular area. If we know that 60% of the occipital lobe is subserving the macular function. So isolated based on the VEP alone, we will not be able to detect whether it is a optic nerve function or a macular dysfunction when there are no other associated signs like an relative afferent pupillary defect, etc. So we always have to complement the VEP with the pattern ERG, and we should know that it is derived from the macula and the retinal ganglion cells. So it gives a meaningful evaluation for the VEP to exclude a macular cause of the VEP function. So how do we interpret this PERG? There are two peaks, P50 and N95. P50 is derived predominantly from the macula, and N95 also has macula and the retinal ganglion cells, and N95 is exclusively from the rest of the retinal ganglion cells. So selective P50 reduction or delay can characterize macular dysfunction, and selective reduction in N95 with a normal P50 suggests dysfunction at the retinal ganglion cells. So we see some examples quickly. A compressive optic neuropathy, as we have seen, both delays both the peak as well as the N95-P50 ratio in a pattern ERG, and there is a delay in the P100. There is a delay in the latency of the P100th wave in compressive optic neuropathies. In ischemic optic neuropathy, because there is an axonal destruction, there is a some degree of mild degree of latency delay, but predominantly it's an amplitude reduction in ischemic optic neuropathy. In optic neuritis, because there is a decreased conduction, the latency is delayed, prolonged, and anything more than 8 microseconds between both the eyes is considered significant, and anything more than 150 milliseconds also is considered significant. Toxic optic neuropathy again can cause an amplitude loss as well as the latency delay. Amplitude is grossly reduced. With indirect traumatic optic neuropathy, again there is a delay in the latency as well as there is a destruction of the nerves. So amplitude also is reduced. We can use prognostication. If this ratio of P100 amplitude between the normal and the unaffected eye is 0.67, which is more than 50% of the unaffected amplitude, in general the prognosis is relatively good. However, if the ratio is predominantly reduced, then the prognosis is not so good, as in this case it's only 0.22. So this was a study in our hospital of 41 patients, and the P100 latency was significantly affected even after 1 month in all these traumatic optic neuropathy patients. So in summary, in a suspected or visual pathway dysfunction, perform a PERG. If P50 is normal and this ratio is normal, PVEP alone is abnormal. Pattern VEP indicates a pure optic nerve dysfunction. If P50 is normal and this N95-P50 ratio is abnormal, meaning it's a retinal ganglion cell dysfunction, and pattern VEP also is abnormal, it means that optic nerve dysfunction plus retinal ganglion cell dysfunction. However, if this PVEP is normal, then we may conclude it's a retinal ganglion cell dysfunction. Thank you very much for your attention.
Thank you, Dr. Mahesh, and just stay on the dais, and if I can now invite all the co-instructors to come up. We're now going to have the neuro-ophthalmology rapid fire cases, and we'll get pearls from all of them. Dr. Swati was to cover neuroradiology, but she unfortunately couldn't be here today. Yeah, but we'll have a short discussion on neuroradiology as well there. So, any questions?
Electrophysiology in traumatic optic neuropathy. ERG.
Or any other test.
VEP. So early VEP. Neuropathy VEP, if you're thinking maculopathy, if you think commercial retina, then ERG. But of course, I think they would complement each other. So you may require an ERG and a VEP if you want more. So if there may be simultaneously injury to both the macula and the optic nerve because of the injury. So if when in doubt there, or you have a vitreous hemorrhage and you don't know, the vision loss is very, very poor, is there a traumatic optic neuropathy? Of course, the pupil will help. But yeah, electrophysiology, VER, there, flash VER, increase in the latency, decreased amplitude would help. And of course, ERG would really not tell you there anything.
So, and just one caveat that whenever, obviously in the modern day, you're going to advise electrophysiology only when you have a doubt, when it's not very clear. So it always is useful to advise both ERG and VEP, because please remember, even if there is an extensive photoreceptor damage, your VEP will be abnormal. That does not mean, as what he suggested, that does not mean that patient has an optic nerve problem. Because if the conduction is not happening right from the retina side, VEP will still be abnormal. So it always helps to have both together.
I think specifics to TON, I think we should also advise the visual fields of the other eye, because sometimes there is a chiasmal injury along with the traumatic optic neuropathy of one eye, especially in the blunt trauma where you have a concussion injury. So visual fields of the other eye should also be done sometimes.
Right. So a quick line on neuroradiology in terms of that. So we got essentially when we look at neuro-ophthalmology, in terms of the radiology aspect of it, we have the X-rays which are going to help us catch any gross fractures in the skull. But essentially you got the CT scan and you got the MRI. CT scan is going to be used where you want to look at the bone, where you want to look at any acute infarcts, any bleeds in the system, when you want to look at the orbit. If you're looking at soft tissue changes, demyelination, inflammation, edemas, that's where the MRIs come in, and within the MRIs you have flare imaging which helps with the demyelination. You've got the DWI, diffusion weighted, which is helping with the ischemia. And so therefore you need to know what you want to order, and you also need to look at contrast, because that's going to help you pick up the the inflammation early or any pathology early. So essentially these are the tools and armamentarium that we use for the neuroradiology. So now let's come on to neuro-ophthalmology, and I'll do some cases rapid fire. These are all simple. I mean, these are all cases that we'll come across, the classic cases, and we'll get some pearls from the co-instructors, our experts right here. So the first case is a young female who's presenting with an RAPD in the left eye. There was a subacute vision loss. You can see that the left eye vision is lower than the right eye vision. The color vision was affected in the left eye, and this was out of proportion to the vision. And the fundus that we can see here is showing a edema or a hyperemic looking edematous disc that you can see here. So this is similar to what Dr. Rohit had presented earlier, and these are cases of papillitis. And so Professor Rohit, how would you investigate this patient, and what would you do about it next?
So a young female, sudden loss of vision, moderate to severe, left afferent pupillary defect. You have color also affected, although with that vision anyway color would be affected, so you need to actually ask how much more severe, or what is the amount. Is it more than you're expecting it to be more? The rest of the fundus is essentially normal. The neurological exam is normal. So we have all the information that we essentially require. My differentials are going to be optic neuritis as my first go. Of course, we need to do the visual fields as was discussed of the other eye. In fact, the moment you have an affected eye, the most important investigation to do is to do the field of the other eye, so that you are sure that you are now dealing with an anterior visual pathway defect, pre-chiasmal. If the other eye, right eye visual field is absolutely normal, I'm thinking of the optic nerve involvement in the left eye. My first differential is going to be optic neuritis. If I suspect that, my first investigation of choice will be an MRI, brain and orbits with contrast, fat suppression for the orbit and flare for the brain. This is going to give me an idea about the optic nerve involvement in the left eye, and if there are any other features in the brain which may be suggestive of multiple sclerosis or NMO. First intervention is going to be IV methylprednisolone as mentioned for 3 days, and depending upon my response, I'm going to take a call on what other investigations I'm going to do. First event, I may not, especially if the vision starts recovering, I may not do too many extra tests, but I will discuss with the patient the risk of recurrences that they may be there. Give an IV methylprednisolone for 3 days with an oral taper. If she recovers well, just follow her up, and then of course advise her for recurrences, and take it from there.
Perfectly.
MRI must be done now in the first episode. Suspect neuritis or any optic nerve problem, must an MRI, brain and orbits with contrast, fat suppression for the orbit, flare for the brain. If you can't remember all this, MS protocol. It's called a multiple sclerosis protocol of an MRI.
Or you can tell the radiologist that you probably are suspecting inflammation, and they will be able to do it. And the things will change. So beautifully summed up for this patient. But just to extend a little bit more, if the visual acuity was very poor on presentation, if there was a bilateral presentation, or vision did not improve, as Rohit mentioned, that all this is when for this patient when vision improved. But if that didn't happen,
this is the case that we're looking at now.
Okay.
This, in fact, Dr. Rashman only has to discuss for us. So this is a patient who's got, who's having a vision which is very poor. There is a bilateral swollen discs that are appearing. There is a papillitis. Again, it is it's a female in that age category. You can see that there is an involvement of both the optic discs or the field in both the on both the sides. There is an edema on the OCT. You can see that there is a delayed latency in the electrophysiology. So all three of these are helping us, with our diagnosis. Now you look at the MRI, and you can look at both the optic nerves are showing enhancement. There are thickening right up to the chiasma. You can see a lesion on the cord as well here that's there. And so yeah, and you do some tests called the MOG, and it turns out to be positive in this case. So this is now for you, over to you, Dr. Ashwin.
Thank you.
Yes.
We didn't plan it, but it
It
happened
was
that
not
way.
planned.
So this actually highlights what Rohit was saying and what Ankur mentioned, that we have to do MRI for everybody. Why? Because in this patient, it turned out that the optic nerve is thickened. So that's called perineuritis, which is very suggestive of MOG positivity. Now contrast it to somebody who had a lesion but much more posterior, like lesion which involved optic tract, lesion which involved hypothalamus. Then you know that you're probably dealing with NMO related optic neuritis. Why we need to know about these two, especially NMO, is because they are much more likely to develop paraplegia, number one. Number two, these are the patients who will require steroid sparing immunosuppression for a very long time. Also, these are the patients who nowadays neurologists would be very aggressive to go through plasma exchange therapy, because if plex is done early enough, probably you have saved. We don't know whether we'll be doing anything with the vision, but at least we know that we have saved the morbidity, the neurological long-standing morbidity for this patient. So I think that's what it highlights, both these cases, MRI, brain in orbit, what Rohit said, for everybody who you suspect as having optic neuritis. Poor vision, bilateral involvement, any other neurological problems, you have to be even more aggressive. Get the neurologists on board if we are not really expert in dealing with it, and tell them that this can be antibody mediated optic neuritis. There are two antibodies that we now know, which is NMO and MOG. MOG, as I said, MRI would show thickened nerves. NMO, the MRI would have a lesion which is much more posterior.
Yeah. All right. So let's come to this another case. Now here you've got a male patient who's presented with subacute gradual onset of vision loss that is happening over time. He's been on ATT, he's been taking ethambutol, linezolid. You can see that the discs are getting, there's a temporal pallor that is developing in both the fundus, both the optic nerves. When you look at the fundus, there is a color vision defect as well. So, and you look at the visual fields, this is typically what you're going to be seeing are these central, or these central scotomas that are there in both these. So you can see a depression in the central visual field. So this is a case of toxic optic neuropathy. Dr. Ankur, how would you approach this patient, and I mean, how would you manage him?
Whenever we have these patients, we have to first look in terms of kind of finding out whether the disease is causing the problem or the drugs are causing the problem. And we know the disease also is bad and the drugs also are bad. But most of these patients do have ethambutol in their part of ATT, and these days we have the treatment protocol which gives the ethambutol for a very long time. And these patients have never been screened or been assessed ophthalmologically before the start of ethambutol. So ethambutol, linezolid, they are all known to cause these optic neuropathies. So the first and foremost, as is written correctly, is like you do a visual field. Visual field will help us find out the etiology that it is looking like a toxic optic neuropathy. The first thing is to stop the errant drug, which is ethambutol or linezolid, and maybe give them multivitamins, vitamin C, ubiquitin, and all kind of support in terms of nutrition, antioxidants, good diet, so that at least some recovery can happen. And usually some recovery does happen if the insult is not too for a very long time. And then discuss with the physician also that they can substitute some other drugs, sparing these drugs from their regime, because you don't want to have an MDR or a difficult tuberculosis for these patients.
Anything you want to add?
Just one more point. I mean, he summed up everything, but it appears now, I don't think I can quote any study or I'm aware of it, but it appears that adding zinc to your multivitamin seem to have a role here, because it boosts up mitochondria.
All right, so let's look at these videos of this patient who's presenting. You can see that there's an abduction defect. You can see some nystagmus that's happening on abduction in the right eye. Let's look at the other one's not running. So whenever you're getting these ocular mobility problems, the deductions on their own, they seem to be working okay, but it's only in one case. You're getting an adduction defect in the left eye, you're getting an abduction nystagmus in the other eye. So when you're looking at extraocular motilities, you can actually look at changes, you need to evaluate both the ductions and the versions. You also need to evaluate convergence or near reflex. So these are situations which are basically going into, the IN or the internuclear ophthalmoplegia. So how would you, Dr. Mahesh, how would you look at, what would you do next to evaluate something that looks like this for you?
Yeah, so she's an young patient and it's a bilateral internuclear ophthalmoplegia. So by teaching, we think that usually it could be a demyelination in the young patient if it is bilateral, but then in any case we need an MRI as has been rightly done. And in this case, since she is an young diabetic, she has unfortunately developed this infarct in the brainstem, and we need to immediately refer this to the neurologist for heparinization and anticoagulation, and that is what we would do, and earlier the better.
And if it was a demyelination, then of course we want to
steroids we would give.
Look at steroid therapy.
MS protocol. So MRI is mandatory as has been done already, and for the residents, for teaching purpose, they need to know what is an anterior internuclear ophthalmoplegia and posterior INO, where convergence is spared or convergence is affected. Anterior meaning that midbrain, and posterior meaning that because the MLF is long, it extends from the midbrain to the pons, and it could be affected anywhere, sparing or involving the convergence.
Right. All right. Let's look at this. He's a young male, otherwise overweight, obese. Was taking, lots of. He was on, doing a lot of gym training. He was taking certain forms of steroids and all to enhance himself there, and he presented to us with. These very, very swollen looking discs in both the sides. You can see very frank, papillary edema with these peripapillary hemorrhages all around, and he was also, on some other medications that he was taking for another hormonal issue that he was having alongside a lot of the other things that he was taking. You can see that the vision was less. So this case, and when you looked at him, between the first visit that he made to me, I'm showing you two fields, that are just about a week apart. So this fulminant kind of papillary edema, look at how quickly the discs, how quickly the field has constricted within a period of 1 week, despite starting him on some kind of a therapy. So these are, so how would you, Dr. Ashwin, how would you evaluate this patient? What would you do next if somebody like this presents to you with a sudden severe papillary edema, fulminant papillary edema, and worsening?
So I think one important message is that these kind of patients can actually progress very fast, very, very fast. It is potentially blinding, so we have to act very fast. The investigation would be MRI and MRV. You are looking at thrombosis of the venous sinuses. You need to get a neurologist very early in the management. I would say that if the fulminant papillary edema, if the visual optic nerve function tests are deteriorating very fast, these are the cases where something interventional apart from Diamox, maybe because Diamox may not really get him back quickly. So now what are the interventions, surgical intervention which can be done? Optic nerve sheath fenestration, if you have access to it, it is believed that optic nerve sheath fenestration is a transient temporizing matter, but in these patients at least you are arresting a further vision loss. A lumbar drain to say that get the pressure down, or even the shunt. Now VP shunt and LP shunt, you have to remember that these patients can have a slit ventricle, so though VP shunt is more preferable, but it may not be possible. So LP shunt is what can be done. So I would say that a very aggressive intervention is required, and most of the time they may end up having a surgical intervention.
Absolutely. So this is absolutely right. So there was a venous sinus thrombosis that had developed actually, and he was one of those situations who was not overweight actually because of fat, but because of having bulked himself up that much. And this is a case where we did an ONSF because while they were still tackling the venous sinus thrombosis, we didn't want him to completely lose out all his vision, because that takes time from the neurologist standpoint. And he's been doing okay after that for us. We'll come to any questions so far. Anybody wants to ask something? We'll come to our last case, I think, and then we'll take any questions. So this is an elderly male patient who's presented to us, who's had headaches, temporal headaches, jaw claudication, high ESR and CRP, as you can see. I'm just trying to put the typical classical pictures that you will get, with a vision loss in both the eyes and a severe vision loss in both the eyes. And look at what's happening to him over the next few days, even as we are treating him. He starts with a disc which is looking, edematous, margins are blurred, bilateral bilaterally. One of them is already developing pallor because by the time he realized he has a problem, one disc was already fairly affected. And over a few days, just look at, this is hardly a few days, how the severity of the pallor, the palate disc edema that is actually setting in. And he's got this inferior altitudinal defect in one of the eyes. We could only capture that. The other eye vision was too low to do any visual field. So what would you look at doing in this, Dr. Rohit, Dr. Mahesh, if you could both weigh in?
So, when you look at the patient profile, it's an ischemic optic neuropathy. You would, the severity, bilaterality, age, that severe palate disc edema, as we had talked about, would consider arthritic as a predominant cause, and that's the most important thing you need to do. You need to do the, as mentioned, ESR, C-reactive protein, and also platelet count. These are the three things that can help. Temporal artery biopsy, we haven't been doing because one, we lack the expertise, and two, there are so many skip lesions that you can miss, and you're never actually supposed to wait for the diagnosis confirmation by pathology. So the treatment, now you could argue versus IV versus oral, or even if you're giving IV, you would give conventional doses. I would hesitate to give mega doses or 1 gram in elderly patients. I would still give conventional doses to these patients, because your aim is to give steroids in the standard anti-inflammatory doses. I would give standard doses, IV to just give a one start and then shift to oral. The aim is to continue this for very long till your ESR starts coming back normal, and then only start tapering in these patients, which may take up to a year or more of therapy. So this is the way, as has been mentioned. Like I said, IV would be equivocal. I mean, is a little, can be decided either way. But yes, methylprednisolone or oral steroids and a long follow-up.
Dr. Mahesh,
So I essentially agree with all Dr. Rohit had said. And one more thing, I might involve a rheumatologist in the long-term care of these patients to assess the other parameters.
Right. And so any questions anybody has? Yes, before we...
So it's not standard of care to give methylprednisolone or any steroids in a traumatic optic neuropathy. Very early presentations, there is anecdotal experience, I won't say good studies, but that in very early, in the absence of any other neurological injury, giving IV methylprednisolone may help in the recovery.
But no mega dose.
But no megadose. I mean, the standard, you can give 1 gram as the originally described megadose were too high and has been found to have serious effects, especially in the presence of neurological issues.
So we should remember the crash study which said that severe head injuries we should not give. For example, if there's a CSF rhinorrhea, there is a skull base fractures, there is a communication, so it's better to avoid. No medico-legal issues in that. We can always defend.
That's what I was about to say, that steroids can be given, but if it's a polytrauma, leave it to the acumen or the neurologist or the person who's handling it. So you can advise that it's required, but based upon the situation of the patient, you may give, because there's a risk of infection or something else which can come up.
Thank you everyone for attending this on a early morning, on a Sunday morning, on the last day, and it was indeed a pleasure to interact with all of you. Thank you.